Today is the 1st of December and today is World AIDS Day. World AIDS Day is held every year on the 1st of December, and it's an opportunity for people worldwide to unite in the fight against HIV, show their support for people living with HIV, and to commemorate those who have died. And World AIDS Day was the first ever global health day, and the first one was held in 1988. worldaidsday.org if you want more information. Also today we are wearing the red ribbon, and the red ribbon is the universal symbol of awareness and support for those living with HIV. By wearing a red ribbon, we are showing that we are aware of HIV, support the millions of people around the world who are living with HIV, and commemorate all those people with HIV who have died from an AIDS-related illness. It's a really good opportunity if you're working within services in your communities to start to enable us to have conversations with people as well. So why is World AIDS Day still important? In Scotland, we are working towards a global target of 0 HIV transmissions by the year 2030. The single biggest barrier for us to achieve this in Scotland is stigma. Fear, misinformation, and still today, moral judgments are the root causes of this stigma. And people who are affected by HIV can affect stigma on many aspects of their lives. So that could be their sex, gender identity, their drug use, race, poverty, sexual orientation, or selling and exchanging sex. Coming together on days like this to learn up-to-date information and for us all to share that information is one of the key actions that we can all take to reduce stigma. A little plug from ourselves from SDF. So you can visit sdftraining.org.uk. We have new dates up there just now for just in the new year. I think 4 dates are available to be booked onto for HIV. We also have our e-learning course, which has just been updated recently. So a free e-learning course called HIV Preventable and Treatable. On Friday, we will be launching our updated resource, HIV What Workers Need to Know, and that is my email address there if you would like to get in touch. So that's all from me. I would really like to welcome now Stuart.
Perfect. Listen, I just wanted to say a quick thank you to everyone who's joining us today for World AIDS Day to listen to what we're going to say. And a thank you to SDF for inviting me along to speak on the Brownlee Centre's behalf. I'm a clinical nurse specialist working at the Brownlee Centre. I've been in my current role as a nurse specialist for about 8 years. I've left my email address down there at the bottom. If anyone needs to contact me, then they're able to do so. So the key questions I've listed here. What is HIV? So HIV is a bloodborne virus. At present, there's no cure for HIV. There's no vaccine in existence for HIV either. Now, HIV itself primarily affects the body's immune system. What happens when someone's exposed to the HIV virus is it targets the immune cells, or the CD4 cells to be more specific, and it infects them, going on to infect the body, causing damage to the immune system. What happens generally at this early stage is the body tries to fight against it, producing more CD4 cells and creating an environment for the HIV virus to proliferate, essentially. What normally happens thereafter is a person would be likely to develop what we call a seroconversion illness, which is the kind of initial illness that someone will get at the point of HIV infection when it develops into a chronic infection. So some of these signs and symptoms would be flu-like symptoms, weight loss, development of oral thrush, cold sores, swollen glands, lethargy. So I also wanted to kind of, at this stage, differentiate between what is HIV and what was referred to as AIDS, acquired immunodeficiency syndrome. So AIDS is not really a term that we use very often anymore in clinical practice. We'd refer to it more as advanced HIV illness. So if someone has HIV that's been unrecognized or untreated, then it will continue to cause damage to the body's immune system, making it extremely vulnerable, and there's an opportunity there for opportunistic infections. So some of the kind of presentations we might see in clinical practice from advanced HIV illness would be a Kaposi's sarcoma, PCP pneumonia, non-Hodgkin's lymphoma, and extensive esophageal candida. When someone has more advanced HIV illness, it means that there might be more difficulty in attaining more immune recovery, essentially. So HIV, as I've said, is a bloodborne virus. It's transmitted through blood-to-blood contact. Of course, anyone could potentially be at risk from HIV. Its main kind of pathways of being transmitted would be through sexual contact, or maybe sharing of injecting drug paraphernalia. Also, before 1992, unscreened blood products had caused HIV transmission as well. Also, in some kind of developing countries where the healthcare practices are suboptimal, there could also be a risk there too. So, what can we do? What can we do to combat HIV? I've said there's no cure, there's no vaccination. Well, I guess one of the key elements is recognizing the signs and symptoms early, so someone is able to engage with specialist care services, and also increasing the availability of testing would be another thing we can do, and also treatment. So that takes us on to my next slide, Lesley, please. So when someone is diagnosed with HIV, they're referred on to our specialist service here at the Brownlee Centre, where they'll see one of our team. It will be a nurse specialist or an HIV consultant who will undertake a clinical assessment of the patient. We'll want to do fairly extensive blood monitoring, looking at the HIV virus itself, maybe if there's any pre-existing resistance there. We'll look at immune function, and as I've said, a clinical examination. Now, the research would indicate that early initiation of antiretroviral drug treatment will mean better clinical outcomes for people. So it is important that we're given an early opportunity to diagnose people and to treat people when they come into clinic as well. So the treatments, we have a lot of different treatments, essentially oral tablets given in combination therapy. We're looking at a minimum of 2 different drugs given in combination. Now, sometimes that can exist in a single pill, but adherence is one of the main things that we need to address in clinic, because the treatment is highly effective, but it needs to be taken every day. So if we can get someone on treatment, as I say, we're not going to cure their HIV, but we are going to suppress the HIV virus from making copies of itself, essentially, and going on to cause further damage to the body and the body's immune system primarily. So by treating early and by suppressing the HIV viral load, we can reduce the risk of onward transmission of HIV virus as well. So the last point there I've made is about engagement with care. So our treatments are only as good as people who are able to engage with our care services. So prior to 2015, when we had the HIV outbreak amongst people who inject drugs, it was solely a hospital-based system where people had to come to appointments. Now, as nurse specialists, we had been dealing with a number of people who had difficulty engaging with the appointment systems here. So we were kind of used to doing some small level of outreach work to try and maximize people's engagement with our services, so they're able to get treatment. Because of course, if you miss appointments and you're not able to come, then you're not able to get the medicines which were dispensed exclusively from our kind of on-site hospital pharmacy. So what are some of the barriers to care? Well, confidentiality is something that's very important to our HIV positive service users. And that's something that we're always acutely aware of, especially when working in conjunction with other healthcare services and third sector agencies also. As Lesley had mentioned earlier on, stigma is a big part of HIV care and something we're always very mindful of. There is stigma from the community in general, or there can be rather, stigma from the community in general, and also self-stigma from people too. Some of the other barriers to care existing would be welfare issues. If people don't have enough money to be able to get to their hospital appointments, maybe they have other health conditions which might limit their ability to actually physically get to clinic. And of course, addiction issues. We are talking about people who inject drugs here. That's the focus of today's sessions. So, you know, coming with addictions issues is difficulty engaging with care services. You know, it's maybe lower down on their priority list is coming to clinic to see us in Gartnaval Hospital to manage their HIV. So disengagement from services is indeed a barrier to care also. Bearing those barriers in mind, in 2015, when we had the HIV outbreak, we need to think about new innovative approaches, because the model of care, the standard model of care that we had in existence, as I've said, hospital-based, and we had kind of recognised fairly early on when we'd seen a higher proportion of people who inject drugs being diagnosed in Glasgow, that we needed to do something to be able to allow them to access the care that they needed. You know, one, for their own health, and two, also to help prevent the onward transmission, knowing that if we could get people on treatment and suppress the HIV viral load, then we're in a position to hopefully help break some of those kind of transmission chains as well. So how did we go about that? Well, at first, our nurses kind of went out into the community, primarily to the homeless addiction team, where we're trying to engage with some of the service users that were already attending that service. We look to try and make links with various third sector organisations, Simon Community, Glasgow Drug Crisis Centre being a few of those, as well as some of the homeless hostels in Glasgow as well, to try and engage this group with our care services. So over time, we're able to get more funding and be able to commit more staff to this. So now we have a team of nurses who work exclusively with the HIV outbreak cohort. That's their full-time role, whereas myself, I work here at Gartnaval Hospital, and I have been involved in the setting up of some of these clinics, whereas I'm not quite as involved anymore. So we've got 3 full-time clinical nurse specialists working within this service, and we have a healthcare assistant as well. We have consultants who are heavily involved in providing clinics in the outreach areas as well. And also, when I mentioned about the pharmacy, it's a treatment that was only dispensed by our specialist pharmacy here on site at Gartnaval Hospital. One of the kind of keys to getting patients on treatment and able to adhere to treatment long term was dispensing of antiretrovirals through community pharmacies as well. So we're able to link our medicines in with the prescription of opiate replacement therapy, essentially. So we know the person's going there on a daily basis, and through conjunction with the community pharmacies, we're able to get that initiated in the first instance, and also sustained more long term. What I would say in terms of the kind of patient demographic in Glasgow, in terms of people who are living with HIV, pre-2015, we did have a very comparable demographic to that of other UK cities. Whereas now, because of the outbreak, we have a bit of a higher prevalence, which is one of the reasons we really wanted to get this group of patients engaged with the service that we're able to offer, and we're able to adapt a service model that was fitting their needs, essentially. You know, and the picture there I've just used is a Joker from Batman, and with the hospital behind them. So I've really just put that on to kind of symbolise our moving away from hospital-based care into outreach care, essentially. So that's a fairly brief summing up of what the service we have here and what we've tried to adapt to best fit. And you know, I would like to give a bit of a shout out to my colleagues who work exclusively in that area, who do all the hard work in terms of engaging with the people who inject drugs who are HIV positive and continuing their care in the outreach environment. I've left my details here for anyone who wants to get in touch with me. I'm more than happy to speak with anyone at any stage about HIV and certainly if I wouldn't be able to help you, then I would ensure that I was able to pass your inquiry on to someone who was. Thank you.
Thank you, Stuart, so much for that presentation. Just going to welcome Lynsey on to present. Lynsey is the lead nurse for sexual health outreach at Sandyford and homeless addiction team in Glasgow. So Lynsey, you ready to go?
Hi everyone, thanks for coming, and thanks to Lesley and SDA for having me. So as Lesley said, I am the lead nurse for the sexual health outreach team. We are from Sandyford, but I am based within the homeless addiction team. I'm just going to give a wee overview of our service and also a little bit about our HIV prevention work. So the Sandyford outreach team was started back in early 2018 when myself and a colleague were asked to carry out HIV contact tracing with those who were diagnosed as part of the outbreak. As Stuart said, the Brownlee had moved away from hospital-based or primarily hospital-based HIV care to an outreach model, so we did the same. Sandyford hadn't really had an outreach service before we started. There was a little bit done, but not really to the extent that it is at the moment. A lot of people who were diagnosed early on. So by the time we started in sort of 2018, there was close to maybe 100 diagnoses, and many hadn't had any contact tracing done. So we started from the beginning, and up to today, we do believe that we have now carried out contact tracing on everybody who is an active patient within the cohort. And based on the contacts information that we've had, we have also tested or arranged testing for the vast majority of those contacts. So when we moved to the homeless addiction team, the other thing we noticed was a gap in the provision of routine sexual health care within the addiction community. Most weren't able to navigate the appointment system that was offered by the mainstream Sandyford services, but they needed support, especially things that we were coming across were long-standing genital symptoms and contraception provision. Access to all of our services, but for our Sandyford service should be equitable. So by being based within the homeless addiction team, it meant we were able to shape our clinics to suit the needs of anyone experiencing homelessness and addiction. We are entirely flexible in our approach and how and where we see patients. We run clinics every day at Hunter Street at the homeless addiction team, and we also do weekly clinics at the Drug Crisis Centre and twice a week at the Simon Community Access Hub. So we provide everything that mainstream Sandyford provides: contraception, emergency contraception, STI screening, BBV tests, smear testing, pregnancy tests, antenatal support, abortion support, and PEP and PrEP. So a few of the key interventions that we look at when we are wanting to promote HIV prevention. So firstly, condoms. Everybody knows about condoms. The funny thing about them is that they work best when somebody has one on them just as they are about to have sex. So they are widely available, free of charge. They're easy to use for the vast majority of people, and services can also request supplies via the free condom service at Sandyford. What we find here is condoms come to us pre-packed in packs of 12, so they're pretty bulky to carry. A lot of our patients don't carry bags or maybe even have accommodation to go to afterwards, so we split the packs and we offer to give them maybe one or two at a time, and it just means that at every opportunity we are offering condoms. IEP, so using clean injecting equipment for every injecting episode removes the risk of BBV transmission, as well as reducing the risk of other injecting related complications. BBV testing, and as Stuart talked about, HIV treatment. So using regular testing as a means of prevention allows quick diagnosis of new cases, and by getting people quickly into care and on to treatment, then we reduce the risk of transmission by reducing their viral loads. For anyone who is injecting drugs, we are keen that the gold standard for testing is every 3 months, but we are aware that the policy at the moment for most places is 12 months. We do have a 3-monthly BBV testing at Hunter Street, so that everyone who is at our highest risk is being tested regularly. As I mentioned, we do the contact tracing. So for everyone who's diagnosed as part of the outbreak, we're looking to speak to them fairly quickly to find out, do they have a regular sexual partner? So that would be our first priority. And then next, we want to look at where this might have come from. So injecting partners or recent sexual partners. It can be challenging in this group. Drug use can diminish their recall of events, and it also needs to be something that we revisit every time somebody maybe falls out of treatment. So if they have had a break in their antiviral treatment and they've maybe had sex, or they have shared injecting equipment with someone at a time when their viral load might be detectable again, then we want to revisit the contact tracing at that point. We work really closely every day with the Brownlee outreach team, so we get that information really quickly and we're able to act on it. For the contact tracing, we mostly use what's called a provider referral method. So in sexual health, when you're diagnosed with a sexually transmitted infection, you're offered the opportunity to either tell partners yourself and allow them to contact services, or that the clinician can do it on your behalf. This is done completely anonymously, so it removes the person with the infection, the index person. So we will get in touch with the named contacts directly to let them know that we believe they may have come into contact with HIV. And as you can imagine, it can be a pretty scary conversation to have or phone call to receive. So it just means that if we do it, we can also give them support and offer a plan immediately to get them tested and into treatment if they do test positive. PEP and PrEP, which I'm going to talk a wee bit about in the next slide, please. So PEP stands for post-exposure prophylaxis, and it is a combination of HIV drugs that's taken after someone has potentially been exposed to HIV. It needs to be taken within 72 hours of the risk, but ideally for maximum effect, you want it to be taken within 24 hours. We dispense PEP from Sandyford, so from any Sandyford service and the outreach team. We stock PEP here at Hunter Street and at our outreach clinics at the Hub and the Crisis Centre, or out of hours or at any time of day really. It is available from A&E, and the follow-up for that, if it's a needle stick injury or any injecting related risk, is through the Brownlee service, and for any sexual risk, it's through ourselves at the Sandyford service. PrEP, on the other hand, stands for pre-exposure prophylaxis. So that's a similar medication that's taken by people who are HIV negative to lower their risk of getting HIV from sexual transmission. PrEP is available on the NHS, so since 2017, to people who meet the eligibility criteria. There are 4 criteria that must be met, or no, they have to meet one of 4 criteria in order to be eligible for NHS funded PrEP. We do also support people who don't meet the criteria but who choose to purchase PrEP. So we would support them with their follow-up testing and care. But PrEP is not currently available to prevent HIV transmission solely from injecting risk. But the outreach team, we do run a PrEP service for people who inject drugs. There does still need to be a sexual element to their risk, so we can't just give it to everybody who injects drugs. There has to be some form of sexual contact, so that might be sex with someone else who injects drugs. It might be that they are involved in transactional sex, either through selling sex or through the purchase of sex, or just really anyone that we believe is at high risk of HIV. It is managed through the outreach team, and as Stuart said, in his presentation, we follow a similar model for community dispensing. So we do offer medication away. It would be initially a month and then every 3 months after that. But a lot of our clients can't negotiate a constant adherence. So we do also offer a community-based service where their tablet is dispensed every day alongside their ORT. We have also amended it so that if somebody's getting take home for a few days, then they'll also get their PrEP to take home as well. Just a little bit about our HIV prevention service during COVID. Like a lot of places, we were overnight, immediately our face-to-face clinics were closed. So we had to find a way around it. It wasn't something that we could move. The models of other clinics that were moving to perhaps telephone consultations, video consultations, that was not something that we were able to provide or that would be acceptable to our group of patients. So around 600-ish, I'm sure, people were accommodated across a few city centre hotels, but for us and for a lot of other outreach teams, that meant we had just a few locations to be able to see patients. We were also receiving information widely about an increase in injecting drugs, also a shift. There was a lot of younger people coming into the hotels that were naive to injecting. They were maybe starting for the first time. They were being injected by peers, or they had poor injecting practices. There was also, we were receiving quite quickly an increase in referrals for sexual assault. And so we had to try and very quickly mobilise ourselves and work out how we were going to deal with this. So the IP van that runs from the Drug Crisis Centre in the evenings, supplying injecting equipment and another variety of services, we were able to access it during the day. And we used it as our clinical base. We couldn't do absolutely everything in it, but we could do most things in it. And we also worked in partnership with lots of other services. So we would go out with the physical health nurses who would also be able to provide wound care. We would go out with the Brownlee nurses if we were looking to maintain somebody on treatment. And it was great. It was really good. It worked really well. That's me in the driver's seat, and that's my colleague Lisa, who it was predominantly us that ran our van service during the day. We do now have our own clinical van. So Sandyford purchased a van on the back of the success of basically winging it last year, but it worked really well. But one thing that we do need to be mindful of following the closure of the clinics is the reduction in testing that we've seen. So we really need services now that things are opening back up to push on promoting testing and or offering testing, so whatever your service can provide. Please get in touch if we can help with anything that I've mentioned to date, but in particular, if someone is looking to test, there are plenty of opportunities for that to happen, and not just through our service. There are lots of other services that offer testing, and also there's the WAND initiative that is happening in the city centre, where people can receive £20 in order to have a variety of harm reduction interventions done, one of which is a dry blood spot test. Thanks. That's me.
Thank you, Lynsey, so much for that presentation. Thank you. Sophie, at this point, any questions?
To Lynsey, with respect to HIV medical treatment offered, do you find it difficult after the initial engagement with the patient to keep people coming back for treatment, particularly active drug users who inject, who inevitably have a chaotic lifestyle?
So I am not involved in the treatment of HIV. So I wonder if Stuart wants to come back in. So that's the Brownlee Centre and the Brownlee outreach team that provides the HIV treatment.
Yeah, thanks for inviting me back in there, Lynsey. Yeah, it is definitely a challenge, no two ways about that. But we do have a very high success rate in keeping people on treatment. You know, a lot of resource in our outreach team goes into kind of, not tracking's not the right word to use, but they're looking for the movements of patients when they go from accommodation to accommodation, and if they're not going to their community pharmacy to pick up their antiretrovirals alongside their opiate replacement therapy, then that's something that we have feedback inbuilt into our service. We get called from the community pharmacies regarding that, so we're able to kind of intervene at the earliest opportunity. I would probably say there's 90-90-90 guidelines in HIV medicine, which looks at the amount of patients who should be on treatment. 90% of patients on treatment who are living with HIV, and 90% undetectable. So when, you know, myself and Lynsey had mentioned as well about the goal of HIV treatment is to suppress the HIV viral load. So to make the HIV viral load undetectable is the turn of phrase that we use. And, you know, I would comment to say that certainly with this group of patients, we're actually managing to achieve that 90% and beyond.
We'll move on now to, we'll welcome Julie Craik, please, who is the Public Health Programme Manager for Bloodborne Viruses for NHS Greater Glasgow and Clyde. And Julie will present on just an update on the outbreak from the incident management team's perspective. So
thank you to Lesley and to SDF for inviting me to update on the HIV outbreak today. So as Lesley says, my name is Julie Craik and I'm the Public Health Programme Manager within NHS GGC with a remit for bloodborne viruses. And my role is primarily responsible for coordinating the delivery of a kind of portfolio of bloodborne virus work across the board area in collaboration with multidisciplinary teams and other agencies. So I came into post about just over 2 years ago, and since then, as you might expect, much of my focus has been on bloodborne virus transmission among people who inject drugs due to the ongoing HIV outbreak, which will be discussed today, and also national ambitions to eliminate hepatitis C as a public health threat by 2024. So I've been asked to give a brief overview of the current situation with the HIV outbreak and a bit of detail about the IMT, which is the group that oversees the response. I'm aware that I might not cover everything that people may wish to know, and therefore for anybody who's looking for a bit more background and detail on the outbreak, there are a series of published papers that Lesley or myself can direct you to, and I would also signpost you to the STF YouTube channel, where you'll find presentations from other colleagues who I know have spoken very eloquently on this topic previously. So the purpose of this slide, which I've borrowed from colleagues in Public Health Scotland, is to give you a bit of background context, and some of it may be very familiar to you. But you can see from the graph that following a peak of diagnoses of HIV in the mid to late 1980s, and following the introduction of harm reduction measures such as needle exchange programmes, there was a period of about 25 to 30 years where the number of diagnoses of HIV related to injecting drug use within NHS Greater Glasgow and Clyde was stable and relatively low at about 10 cases per year. In late 2014 and early 2015, we had intelligence coming from the West of Scotland Specialist Virology Centre and third sector colleagues, which was suggesting there may be a bit of a situation and an unusual kind of number of people being diagnosed with HIV that was related to injecting drug use. And you can see from the graph that in that sort of year, there was a significant spike in the number of cases diagnosed. Just as a reminder, the outbreak occurred despite extensive harm reduction measures, which is quite unusual compared to other outbreaks that have occurred elsewhere, and was associated, work that was done by colleagues showed that it was associated with homelessness, incarceration, and a sort of shift towards cocaine injecting that we were seeing. So in response to that intelligence and the sort of increase that we were seeing in 2014, 2015, an incident management team was formed, and this is chaired by a consultant in public health within NHS Greater Glasgow and Clyde. It's a multidisciplinary, multi-agency group whose overall responsibility is to investigate and manage the outbreak and put in place control measures to reduce further transmission. So since, you know, the IMT was first formed in 2015, such measures have included awareness raising, training, briefing with key partners, agencies and people who inject drugs. There's been expansion of needle and syringe provision, including weekend cover, and there was the introduction of lower dead space syringes as well. There was actions were taken to ensure that those diagnosed had prompt access to ORT. And as Lynsey and Stuart have described, there was the introduction of revised sort of treatment service models, the introduction of things like the contact tracing into the homeless addiction team. And one of the key actions was to scale up through key services such as our alcohol and drug recovery services, prisons and acute services to try and upscale testing, which is fundamental to ensuring better outcomes for individuals, as well as enabling us to operate that effective sort of treatment as prevention strategy that Stuart and Lynsey have both described prior to me coming on. So the IMT meets on a quarterly basis and we review the epidemiology, testing levels, harm reduction provision and treatment measures, as Stuart described there, you know, the proportion of people who are on treatment as part of the cohort and how many are, you know, the viral suppression rates in the cohort as well. And then we look at planning any required response. The group isn't really meant to be a sort of permanent planning structure for sexual health and bloodborne viruses within NHS GGC. It is an incident management team and you know, we would anticipate that once the outbreak scenario is deemed to be over, that maybe this would be stood down and then the work around HIV transmission in this cohort of individuals would be incorporated into our wider working structures, which will, you know, I know you're coming on or going to be talking about a wee bit later, is around how we eliminate HIV transmission by 2030. So the IMT relies heavily on key partners. I was going to name them all, but I had the fear of missing somebody out, like in a Oscar speech. So I just to say that, you know, it relies on their key partners actively participating and working collaboratively, and it benefits hugely from having very passionate and committed set of individuals around the table from a range of agencies and organisations. Okay, so I think there was a question popping up in the chat around, you know, what the situation is now, and you know, I guess the question might be is, are we still in an outbreak situation? And if we go back to looking at the graph, you will see that in recent years, the annual number of new diagnoses in NHS Greater Glasgow and Clyde linked to injecting drug use has declined from that initial peak that we sort of saw in 2014 or the 2015. However, the number of new cases has remained elevated compared to pre-2015. And although we can see that there were fewer diagnoses in 2020 compared to 2019, we should keep in mind that this was against the backdrop of COVID and the challenges it presented and, you know, continues to present for us. Well, testing at that point was still not perfect, sort of pre-COVID. We do know that over the course of the outbreak, testing has been scaled up significantly in key settings. And many of the people who have been diagnosed in recent years are much more likely to have evidence of a previous test. We can therefore see that using sort of testing history and laboratory data around avidity, it's, you know, we can tell that some of the infections that have been diagnosed in sort of 2019, 2020 are recent infections, and therefore the transmission is or was ongoing at that time. We know that from our work with key partners that and the National Biobehavioural Study, NESI, and the intelligence that we get from that, that prevalence may have plateaued in the city centre in 2019, but there was some evidence to suggest it may be increasing slightly in areas out with. And that was, as I say, the sort of situation at 2019. Increased testing drives and contact tracing work that Lynsey described led to a number of cases being identified in early 2020, just before the COVID pandemic took hold. So how did the COVID impact on the HIV outbreak? Colleagues in Public Health Scotland have done some excellent work around this, and looking at the impact the first wave of COVID-19 and the associated control measures have had on interventions to prevent bloodborne viruses amongst people who inject drugs in Scotland. In essence, what that work has found is that the first wave of COVID did have a negative impact on key BBV prevention services, most notably testing. Lynsey touched on this in her presentation. The reduction in testing, certainly in Glasgow, has largely been the result of revised service models that people had to put into place in response to COVID, which reduced in-person service delivery, and a consequence of which was reduced opportunities for testing. And we have found that for some services, testing is proving hard to remobilise. The concern, of course, is that with any disruption to key interventions, particularly testing, it has the potential to have serious consequences, both for the individuals themselves in terms of being diagnosed late and their well-being, and outcomes as in terms of onward transmission and our ability to operate that effective treatment as prevention strategy as outlined earlier. I don't think that we've got a full picture as to what has happened in terms of behaviours and injecting practices during COVID, but you heard Lynsey mention some of her own experiences on the ground, and through assessment of injecting risk tool that's being conducted as part of WAND, there's certainly a suggestion that there are reasons to be concerned. Reviews of those assessment of injecting risk tools have found evidence to suggest that, needle reuse is happening, that individuals have maybe limited control over preparation process and drugs being prepared by others. Some evidence of direct sharing of needles, although more commonly it is sharing of paraphernalia, which all increases a potential risk of BBV transmission occurring. We're also aware through the AIR tool that we're seeing increasing numbers of people reporting cocaine injecting, which has been identified as a key factor in the HIV outbreak. Also within that is people injecting cocaine only, and that maybe presents some challenges in terms of how we find these individuals and engage them in areas such as testing. The cumulative impact of all of this on bloodborne virus transmission and the outbreak is as of yet unknown, and really more intelligence is required. So just in terms of where we're at, the graph I showed you showed us up to 2020. If I were to add 2021 data, there may be cause to think things that look quite promising, and the number of diagnoses is down compared to previous years. But as we've sort of said, diagnoses are a measure of how many people have been found, and with potential gaps in testing, we cannot be assured, I suppose, that onward transmission could possibly be going undetected. Low levels of testing pre-outbreak and in its early stages have been noted as a possible factor in its fueling its kind of spread early on. And I suppose the concern might be that we could find ourselves in a similar position. That said, I think there is reason to be cautiously optimistic perhaps about the city centre. Testing through services such as the Homeless Addiction Team, Enhanced Drug Treatment Service have been maintained through COVID, and as Lynsey described as well, there's the WAND initiative that's taking place in the city centre, which is providing opportunities for those who are actively injecting to access testing, and there's been over 1,000 tests done, dry blood spot tests done as part of that since it started in September 2020. I think we're all quite eager for the next NESI survey to take place, which will maybe give us a clearer sense of where things are at, particularly in areas outside the city centre. And in the meantime, we're continuing just to work to explore how we can remobilise testing in key services and find new ways of offering testing through different including at home, perhaps through different settings and in conjunction with other health interventions. I think Lynsey indicated in her presentation about the need to remind people about testing, and I would just reiterate that. There's training opportunities are available around bloodborne viruses if people want more information through SDF and also NHS Learn Pro. And just to remind that the importance of testing and signposting and raising awareness of the need for individuals to test every 3 months, particularly if they are at continued risk. Thank you.
I would like to take this opportunity to thank all of our speakers, Stuart Kirkwood, Lynsey Boyd and Julie Craik. We've heard some really important information.